We got it going on. Okay, now, so let's take care of this person. If you go, I believe, actually, it's the weirdest thing. You got to go backwards to find the generic handout that says care of the patient. Just a couple pages back to where you see a page that says treating congestive heart failure. So you have to go backwards. Yep, that's it. This is where we're also going to include some information about meds, and we're going to include some information about preload and afterload, because you have to know which meds work on which, okay? So if you think about treating congestive heart failure, our goal is to decrease the preload and the afterload. Now, so if you see here at the top, it says treating congestive heart failure. Above that, right, complication is cardiogenic shock. Because when we don't successfully treat it, our patient goes into cardiogenic shock, which is crazy as hell. You already knew that. Okay, now let's do the damn thing. First of all, we can't treat what we didn't diagnose. Diagnosis is done with a blood test called B-natriuretic peptide, BNP. B-natriuretic peptide, natriuretic, N-A-T-R-U-I-R-E-T-I-C, B-natriuretic peptide. Now, BNP, that's what all of us call it. BNP is actually a chemical, and you don't need to write this, just understand it. It's just a chemical that is given off by the ventricles when they're working too hard. So whenever the ventricles are working a little bit too extra, we're going to give off some BNP. In this guy, I tell you to remember sort of like a 50-50 plan. 50-50 plan is going to look at the BNP, which is that chemical given off by the ventricles when they're working too hard, and it is also something called ejection fraction. So we're going to look at two things. The blood test is by far the most important, the BNP. But we told you we'd like you to remember something about a 50-50 plan, okay? Ejection fraction actually, I want you to go back, way back with me. Some of y'all can't even go that far back, but we're going to try for what it's worth. If we just go way back, as far back as we can, we had something called 8-track tapes. I know, you're too young to know what the hell that shit is. But suffice it to say, when you press the eject button, you almost got knocked down, it was so big. In case you're not old enough, I'll break it on down on your level. We had something called VHS. You press eject button on there, you probably get hit in the stomach with a big ass cartridge. Okay, now I'm coming up closer to some of y'all youngsters. Y'all might remember something called cassette tapes. You hit the eject button and pop, popped it out. I remember distinctly because our boy just died, but I remember recording over and over and over again my Prince songs so that I could know the words to my favorite Prince song, which was Adore. That's just on the side. Now, when you come up to the 2006, well, not even, 2000, we'll say 2000, you press eject and you got a disc, a CD. This shit don't even exist no more. It sounds like I'm old as hell. I'm just way over 50, but not yet 60. So we're gonna say that we're bringing it up your backyard and down your parking lot, and now y'all got these old stupid PlayStation, MP3 shit. I don't know about it. I know somebody put some songs on my phone and I listened to it. How they got there, I have no damn idea. So y'all spoiled. Now, but back in the day, we had all this shit you hit eject on. Eject was important to you on the test because ejection means pump out or push out. If I'm talking about an ejection fraction for my heart, specifically my ventricles, the pump of the heart, then I would agree, and you would agree, that the ejection fraction should be high. I should be able to pump a nice amount of blood out without a problem. Push or pump out, same as the button. This patient's pump is broken. they're not going to be able to eject much out. If that's true, and then I know that I just told you the chemical when the ventricles are working too hard is called BNP, you'll know which way the 50 goes. In other words, if I'm putting out a chemical when I'm having trouble pumping, then that means the BNP is greater than 50. If I'm not ejecting much blood out, then that means that the ejection fraction is less than 50. You gotta know which way the arrow goes. 50-50. BNP higher than 50, ejection fraction lower than 50. Does that make sense? Okay, so you got it. That's how we know this patient has CHF. BNP is distinguishable as the most diagnostic lab, but then this patient's going to get an echo, and they're going to see the ejection fraction on the echo. Sometimes that echo is called a Muga scan. Sometimes that echo is called a Muga scan. That's a nuclear test. Multi-gated scan. Muga. All right, so let's go ahead and treat our patient now because we got a huge problem. We don't want no cardiogenic shock. Would you agree the upright position just makes common freaking sense? Put semi-Fowlers. And remember this semi-Fowlers is 45 degrees. Right, semi-Fowlers by that. Remember it's 45 degrees. What's the action of nitro? Vasodilation. That'll help us. Now, I would put isosorbide on that one. Isosorbide might be the drug. I told you we're going to know a little bit about these drugs. If it's not isosorbide, and I'm going to erase this because we already covered it. Anything I cover, I just kind of get rid of. So look at these drugs, y'all. Put them all down. We have isosorbide, which is a vasodilator. It's basically nitro. We have Niseratide here, which is called Natricor, and I do want you to know that, so hold on. That's a vasodilator. That might be something that we're using. Okay, so vasodilators, nitro, isosorbide, Niseratide, or Natricor, which is Natricor. Lasix, well, it might be Bumex. So it could be Lasix or Bumex. They're basically the same, but not identical, but they act in the same way. Aren't they loop diuretics? Will they work on preload or afterload? Think it through. Think about what they do, what effect they have on those two words. Preload is volume and afterload is resistance. So what will your diuretics work on? Preload, because you've got to keep saying preload is volume, afterload is resistance. Anything that makes your blood pressure high or cause you to resist the flow of blood in your vessels is called afterload. Preload is volume. Diuretics work on preload. You sort of kind of got to know that. Diuretics work on preload. Oxygen, common sense. This patient needs O2. ACE inhibitors, ACE inhibitors actually work on afterload and preload. They work on both. Because the ACE inhibitor, and I'll go over how it works on both, the ACE inhibitor is just what it said, an angiotensin converting enzyme inhibitor. So if you think about, okay, it's inhibiting angiotensin. Well, what the hell is angiotensin? Well, tensin means tension, and that's vasoconstriction. If I inhibit angiotensin, then I inhibited vasoconstriction. Okay, so if I'm inhibiting or stopping any kind of vasoconstriction, which means the same exact thing as resistance, then I've worked on my afterload. Agree? Now, that was just the angiotensin part of that drug. It inhibited A1 from becoming A2. But the part that students forget is part 2 of what an ACE inhibitor does. An ACE inhibitor not only stops A1 from becoming A2, it stops, if it stopped the A2 in the first place, then the next part of what A2 was going to do has been stopped. Angiotensin 2, if not stopped, would have triggered the adrenals to produce aldosterone. Now that word, aldosterone, which is what angiotensin triggers, aldosterone. What does this part of that word look like? It looks like steroid, doesn't it? Oh, that's kind of important since that damn hormone does exactly the same thing as a steroid. Steroids make you retain sodium and water. If angiotensin 2 stimulated the adrenals to produce aldosterone, and aldosterone makes you retain sodium and water. If I stop angiotensin 2, I stopped the retention of sodium and water, which means I stopped the volume of blood in the body, which means I stopped the preload. Volume, preload, water, volume, salt, water, volume, preload. I stopped it all. I stopped it all with the ACE inhibitor. So I stopped afterload by stopping vasoconstriction, and I stopped preload by stopping angiotensin from stimulating aldosterone, because aldosterone made you retain salt and water. Water is volume. ACE inhibitors work on both afterload and preload, because afterload is resistance, preload is volume of fluid moving through the heart. And I stopped both of those. I stopped you from holding on to the water. I stopped you from holding on to the salt, and salt attracts water. I stopped you from vasoconstriction, which would have given me resistance as I tried to push blood through the vessel. Is it making more sense now? ACE inhibitors are bad drugs, man. They're shit. Every diabetic should be on one, okay? All right, so you're doing a damn thing. Let's keep it moving. Digoxin. Digoxin, as you already know, is an inotropic drug. It strengthens the contraction of the heart. So Digoxin is the bomb.com, because it's trying to strengthen every contraction and therefore help the heart get rid of all this damn fluid. Okay, it's the bomb.com drug. All right. Now, other drugs that strengthen the contraction of the heart, basically your inotropic drugs, dobutamine, milrinone. Let's put all those together. These are ICU drugs as well. Okay, so dobutamine strengthens the contraction of the heart. Milrinone, Digoxin, sometimes they're called cardiac glycosides. Inotropic cardiac glycosides. Okay, they strengthen the contraction of the heart. And well, that would be nice because our pumps are broken. Okay, now this patient with Digoxin, you know this already, but we're just trying to love on you. Digoxin is toxic at what? Maybe you don't know. 2. Digoxin is toxic at 2, and it's likely to become more toxic in any patient with a low potassium. You and I know that the potassium normal is 3.5 to 5.3, correct? Well, I had a wonderful little ICU baby come in here and talk to the class yesterday from our class here. She just sat right there a few months back. And she said, I got yelled at my first week because my patient's potassium was 3.9. In the cardiac unit, we treat 4 and under because it's so important to cardiac function. We can't even afford to let them be borderline. I said, wow, because that's not true on the floors. You don't treat a 4. But they do, because this is a heart center, and where she works at Cleveland Clinic, CICU, cardiac CICU, surgical intensive care. Okay, so it's really eye-opening how much they're going to treat it. But this patient, you got to watch their K, because if you look at the bottom, it says watch their ditch level, and it says watch their potassium. Y'all see that where it says test at the bottom? And you got to know when K is low, ditch is high. When K is low, dig is high. Now, between the words digoxin and fluids, you've got a little tiny bit of space, unless you colored into it with some other words, and that's okay. But I would like you to add a bullet point at the bottom if you already filled that space up. The bullet point that you're adding is daily weights. If this patient had a freaking scale, they would never see you, because they would call their doctors when they gain how many pounds in one day? 3 pounds in one day, 5 pounds in a week. I don't let my patient go home unless they can prove to me they have a scale. Everybody in the country knows you need a car seat to take a baby home. Well, everybody I take care of knows you better show me a scale before you discharge. Because I know that daily weights prevents hospitalization of this guy. 3 pounds in a day, 5 pounds in a week. If you call me as a provider, I'm a provider. If you called me with that, I'm going to say, you know what I want you to do? Why don't you take another Lasix? Yeah, just add one to your repertoire today. Take another Lasix, and I want to see what's going on with you. Are you short of breath at all? I can talk this through. Because all we're going to do when you come see us is do some IV Lasix. And it's really kind of profound how ridiculous what we did could have been done at home. Okay? So this guy needs to do the weights every day. They need strict I&O. Strict I&O. All these IVs are on a pump. Last thing you need is for a whole liter to run away from you. So all of these IVs are on a pump. Okay? Now, this guy, fluids, huh? Oh boy. What did we say about the fluids? Decrease them, yeah? We're not letting them fill up the water jug all day, right? Now, what did that do? Now don't you miss this, or I might have to come up your parking lot down your alley and slap you across the toes. So here's the deal. What did that decrease? Preload or afterload? There you go, because it's volume. This is going to get gooder and gooder. I told y'all. All right? Now, the word afterload is actually on your sheet. It means resistance. Let's think that through. What did I say happened to make this blood vessel crazy? What kind of resistance things happen? Yes, atherosclerosis. What do you use to treat that? This is not a trick question. What do we treat cholesterol with? Statins. Write it down. Statins decrease afterload, don't they? Don't they? Yeah, so they're going to work on the LDL. They're going to lower the LDL, right? So they're going to act on this guy right here, this atherosclerosis. But then your patient might be doing some stupid shit to increase their afterload. What could they be doing? Smoking. No smoking. Put there right next to that one. To decrease the afterload, stop smoking. Take your statins. Stop smoking. Okay, you're going to work this all the way out because I'm tired of y'all. Y'all know some stuff. Y'all are trying to act like y'all don't know, but you know. Look at the next one and tell me what it decreases. One at a time, since you're acting like you can't talk and shit. What does it decrease? What does it decrease? What does it decrease? I said preload or afterload? What does it decrease? What does it decrease? You feeling outnumbered yet? Yeah? Now explain why you're wrong and they're right. No. Stay with me, placenta brain. Yeah. Sodium. You explain it. What do you think? No, it's not. Afterload? No, it's not. Afterload is resistance. I told you to write it. This is resistance. This is salt. What does salt attract? Water. Preload is volume. Now, because I picked on y'all ain't gonna forget this shit. Decreases preload. Write it down. Decreases preload for salt because it attracts water, so you essentially decrease the volume. Now, I'll visit you 14 years from now when you have your BSN and MSN, and you'll be like, I never missed that again. Everything you miss, you remember more. There is a hallelujah with shit you miss, but you can't miss this final, so you better have your shit together. Sodium restriction is preload, everyone, okay? Now, you're doing the damn thing. You did all this crap. Your patient still, for whatever reason, got cardiogenic shock. You have some space at the top on the left or either somewhere in the top. I want you to write cardiogenic shock. I'm going to tell you what's going to happen with this poor guy. Cardiogenic shock is always, always, always going to be remembered on your test as the pump broke. So start with that. Cardiogenic shock, the pump broke. And they didn't just slow down, they broke. Cardiogenic shock, the pump actually broke. All right? Now, if the pump broke, do you have a blood pressure? No. If the pump broke, don't write that down yet. If the pump broke, are you getting perfusion to the first stop off the aorta, which was your brain? If the pump broke, are you perfusing your kidneys? Okay, so here's what you got to remember is the first early sign. The first early sign reflects the first stop off the heart, the brain. Confusion is the earliest sign of cardiogenic shock. Confusion. When it comes to vital signs, you're going to remember you don't have a blood pressure. So it's low. Because the pump broke. And in parentheses, right, the pump broke. Low blood pressure. The pump broke. Okay? As compensation, the heart rate went up. So you have tachycardia. To seal the deal and make sure you know it's cardiac, there are weak peripheral pulses. Weak peripheral pulses. Now, when we talk about circulation, a good trick for you to remember that you probably already forgot from your 1600 were 5 P's. The 5 P's included pallor, paresthesia, pulselessness, all this other stuff. So this patient has weak pulses. That's what's going to make this a cardiogenic shock and not some other kind of shock. Because there's about 6 different shocks. Why my little thing going out? Now, the issue with congestive heart failure and subsequent, don't you love these things? Subsequent cardiogenic shock is really pulmonary edema. So all of this is going to be CHF, cardiogenic shock, pulmonary edema, all in one person. It's a medical emergency. You knew that. Of course, at this point, we have to do a lot of things very fast. We got to get that blood pressure up. That's called dobutamine. Sometimes people like dopamine, and I want to tell you a little bit about both. Dobutamine, as we said before, will strengthen the contraction of the heart, while dopamine will cause peripheral resistance or vasoconstriction. So dobutamine will strengthen the contraction of the heart, but dopamine, totally different drug, is going to cause potent vasoconstriction. And the way you know the difference in the patient, and this will sound confusing, that's why you got to really pay attention. Dopamine causes vasoconstriction, but it dilates the renal arteries. You have to write that. It causes peripheral resistance and vasoconstriction, but then it turns around and dilates the renal arteries. Now, so when you give a patient dopamine, their urinary output increases. Okay, so this patient in shock needs dobutamine. The focus is that damn heart, that damn blood pressure. Blood pressures cannot be low. I mean, come on, the pump is broken. We're going to have to do something to strengthen the pump. These are our cardiac glycosides or inotropic agents like dobutamine. You know the Lasix would be used, IV, to get all this fluid off this patient. So that's that. Okay. Let's move on to something other exciting thing on the board, more chronic cardio. Chronic cardio here at the top, PVD, PAD, HLTT.